I locked the dog out because my dog's been bothering me. He wants to go out for a walk again.
All right, we're recording now.
Okay. Let me see if we can go ahead and share screen. Okay. And okay. Okay, can you all see the PowerPoint? I can't hear you.
Yes, we can.
Okay. It's really hard because for some reason, all I have is the PowerPoint. I can't see you all, even though I hit share screen. So you're all going to have to yell. And I don't know what I'm, okay, so I'll have to go back and forth, I guess. Especially when I want to ask you some questions and see what you think. Okay, so does anyone, now this talk is an adjunct to the lecture that you have tomorrow morning with the other Dr. Underwood, who just so happens to be my son, who's a physical therapist who specializes in dealing with people with persistent pain. And you notice I'm using the term persistent, and a lot of times people use the term chronic pain. But more and more in the literature, we're seeing persistent pain used because chronic pain tends to have a bad connotation. And persistent pain, as I'm sure Dr. Underwood will tell you tomorrow, is more accurate. So anyone have an idea why, when someone would be given the diagnosis or have the term persistent pain given to them, what the criteria would be for that? Does anyone know? You just yell it out. Hopefully I can hear you. Nobody?
Pain on more days, like you have pain on more days compared to the days you don't have pain.
Okay, I heard part of that. Pain, I'm sorry, but Professor Bono or Dr. Allison are going to have to repeat what you said to me. Get close to the pain that what? Because for some reason, I cannot hear you all at all.
Can you raise up, can you put your volume up on your computer? Oh.
I think it's you.
Yes.
I think my volume is up as high as it will go. It is. It's up as high as it'll go. It's that. I don't know if, okay, Amanda?
Hey, can you hear us now?
Yes, I can hear you reverberating through the phone. Are you getting reverberation back?
This is over.
We're going to try the speakerphone, the microphone. Just mute your computer.
Oh, okay.
That won't work. Hang on.
Okay, I'm not muting. I'm sorry, everybody. Now I think you guys are totally muted.
Mute your phone.
mute my phone? My phone is muted, actually. I have you on speaker. You want me to mute it?
Mute your phone.
Okay. You mute, I'm muted. Can you hear me better now?
Yes, can you hear us?
I can hear you. I can hear you a little bit.
Okay, I'm going to use this as a microphone and walk around the room.
Okay, so someone answered the question about persistent pain, and I didn't hear what the answer was.
Hi, I have an answer. I was thinking that you have pain on more days than not.
On more days than not, that's a really smart answer. Anybody else want to add to that? No?
The question was, what is the definition of persistent pain?
Okay, well, I'm going to go ahead and tell you so we can move it. No, someone else has an answer?
We have one more answer.
Okay.
Pain that lasts longer than 3 months.
How smart. Very good. Yay. That's right. So you're both right. It's pain having pain more days than not. And it's pain that typically lasts more than 3 months. It's also pain that lasts beyond the expected time of tissue healing. And as you hear the discussion tomorrow morning, you'll hear about the fact that tissue damage does not necessarily equal pain. Different people, as I'm sure you well know from your field works, you know, somebody could have a knee replacement surgery and complain of severe pain, and another person could have exactly the same surgery and complain of very little pain. So there's a lot of dynamics going into pain. Go way back to your neuroscience. I'm sure some of you don't want to go back to neuroscience, where you learned about nociception. Remember that term, nociception? And nociception is, you know, the process of encoding and processing noxious stimuli. But what's important to understand, and this will be really emphasized tomorrow morning, is that pain is not perceived until it gets to the brain. There really are no pain fibers. And that was a big change in my thinking and a lot of people's thinking in the new pain science. Today, and this is what the focus will be tomorrow morning, is the biopsychosocial aspects of pain. That's how pain is looked at, as very complex and not just, you know, noxious stimuli happens, goes up to the brain, you feel pain. Importantly, there are two other concepts before I start talking about the OT's role that I just want to touch on. And one of them is central sensitization. Dr. Underwood is going to talk about this tomorrow morning. After someone has had persistent pain and it goes on for a while, they can develop what's called central sensitization, which is increased excitability within the brain. So even without pain happening, there's this increased excitability on the dorsal horn of the spinal cord and goes to other parts of the central nervous system. And I'm bringing up this concept because I'm going to be talking about strategies that OTs can do to help deal with central sensitization.
Dr. Underwood,
Yes.
would you screen share?
I thought I did. I am on screen share. I haven't opened up. I haven't opened up. This is not in the presentation. these are things that Matthew's going to go over tomorrow morning. I just wanted to touch on them before I do the rest of the presentation. Okay. I'm sorry if it's a little confusing.
Sounds good. Thank you.
Okay. And just the last concept I just want to mention is peripheral sensitization, where actually after someone has had nociception stimulation, it results in a release of peptides, and you can get what's called inflammatory soup. And so peripheral parts of the body can be very, very sensitive. An example of that is I have stenosis, narrowing of the spinal of my vertebra where the nerves come out in L5-S1. My leg hurts. Now I have radiculopathy going down my leg, but it hurts to touch my calf. That's an example. There's been inflammatory soup that has spilled out into my leg. So I can't, for example, stand having wearing tight leggings on my leg. It really bothers me. So in our way of thinking as occupational therapists, that's a sensory processing issue, isn't it? So that's what I'm going to be talking about. So now I'm going to go ahead and share screen, and this will make more sense as I go through talking about the OT's role. Okay. Well, this is not good. Okay. You can hear me okay? Professor Bono?
Yes, everybody can hear you.
Okay. And let me know, and this is going to be hard because I can't see you, unfortunately.
I will let you know if anything goes wrong on our side.
Okay, because I have, when we get to the CBT, I have some questions and the mindfulness. Okay, so.
I will be your Vanna White.
Oh, thank you so much. Okay, so, when I started, this is actually part of a presentation that I did for the GOTA conference this year. Matthew talked about pain as, the complexity and the biopsychosocial aspects of pain, and then I talked about what the OT's role is. So this will make more sense tomorrow morning after the presentation that he does. But when I think about, start to think about, what's my role with a certain kind of population, the first thing I do is look at what is the evidence out there? What do we have in our field? And we're very, very lucky that AOTA is such an advocate for us, and there's so many resources. So besides the AJOT, so I looked in AJOT first, and I saw in 2011 there actually was an article written by Robinson Kennedy and Harmon, in the issue is, in the back of AJOT, at the very back, there's people write about an issue and their opinion or talk about something they think that the field needs to pay attention to. And what they talked about, and the question was here, as you can see, is OT adequately meeting the needs of people with chronic pain? And I'm sure some of you were in hand clinics for your level 1 field work. And yes, we are working with people who have chronic pain, usually upper extremity. But you also, if you were in a clinic where there were physical therapists working with people other than people having hand injuries or upper extremity injuries like back pain, did you see the occupational therapists working with those patients? Did anyone see the OT working? Anybody?
Anybody have a chance to look at that? No one, everybody's shaking their head no.
No. Very, very limited work of occupational therapists with people with persistent pain, with back pain, pain with leg pain. I mean, we do see people, like I said, for orthopedic, if they have a hip replacement, a hip fracture, a knee replacement, but not people who go to physical therapy. And I'm sure tomorrow morning, and he better say this tomorrow morning, you have to tell me if he doesn't tell you this, that that Matthew, comes to me all the time and says to me, Mom, I want you to see my patient. He needs occupational therapy desperately, but OTs are not working in this area. So basically, there's not a lot of evidence for occupation-based OT. Here, people are not doing the occupations that they need and want to do. There's inappropriate. There's some inappropriate kind of evidence too about multidisciplinary types of interventions, like what we're going to be talking about, cognitive behavioral therapy, OTs using that. And then there's some underuse or relevant evidence about vocational rehab and occupation-based, again, cognitive behavioral therapy that we're going to be talking about. In 2015, there was a systematic review. And again, the conclusion was that we need to build up the evidence. We don't have the evidence about the fact that OT is helpful with people with chronic pain or persistent pain.
Hey, Dr. Underwood?
Yes.
There's some emerging evidence in the area of lifestyle redesign.
Yes, very good. Thank you for adding that. So,
and one of my students added aromatherapy has some evidence too. Yes.
You're absolutely right. Thank you so much for going ahead and adding that. We do have, thanks to AOTA, and this is partly what your dues go to, is the CATs. Hopefully, you all have looked at the appraised topic areas, and we do have a fact sheet actually of occupational therapy and pain rehabilitation. It's very biomedical. We have actually here, as what we're saying as part of lifestyle management, we have AOTA Living Life to the Fullest, Managing Chronic Pain. We have at AOTA, you can download it. There's a CAT about musculoskeletal disorders and what the most effective treatments are. And then there's also in OT practice, there in 2016, there was an article called Breaking the Cycle, the OT's role in chronic pain management. And they began to talk about the fact that we needed to view pain as multi-dimensional and not just biomedical, as many of us have in the past. And also talked about the fact that interventions need to include pain education. And we need to encourage movement. This is a very hot topic because, of course, the opioid addiction. So in 2016, Donna Costa, who's written a lot, done a lot about field work too, went ahead in OT practice and wrote an article about what's our role. And as you can see here, she went ahead and talked a lot about our traditional roles, setting goals, the ergonomics, energy conservation, exercise. She talks about a hot topic, which is sleep, establishing sleep habits and managing stress. And she also talked about the psychosocial aspects and CBT. What's not here, and I'm not trying to criticize her, but it's not explicit here about working on the occupations that people, want to do and can't do. Of course, doing energy conservation and figuring out work simplification would be working on the occupations, but it's not explicit here. So I'm gonna switch now to what's out there in terms of the assessments. When we do evaluation, of course, in terms of a general evaluation, in terms of occupational performance, kind of our gold standard is the COPM, which I know you all have used a lot now. One study did find that there was poor construct validity of the performance scale related to detecting changes in occupational performance of people with chronic pain, meaning that when the people went ahead and rated their performance of the 5, major the occupations, when they had the baseline, that when they redid it, it didn't really show change, or it wasn't really, I can understand that maybe some people's performance went down because maybe they were actually doing more of the occupation more frequently. And so that was something. In terms of specific occupations, one of the kind of gold standard, and Professor Bono knows this well, for a study that she's about to do for sleep, is the Pittsburgh Sleep Quality Index. And I have on the slide, I have where you could see it. It measures a lot of parameters of sleep. It's a quality of sleep index, but it also looks at things like how long does it take a person to fall asleep, and how many nightmares a week does a person have. We know from research that sleep complaints are present in about 67 to 80% of people with chronic pain, and that at least 50% of individuals with insomnia have chronic pain. So sleep is a major issue for a lot of people with chronic pain. And yet, again, occupational therapists are not working with these individuals and helping them in terms of sleep. Out of the general public, it's estimated that about 20% of American adults, about 42 million people, report that they have pain or physical discomfort that actually disrupts their sleep a few nights a week or more. So even the general public have not people that maybe even would be seen for treatment. So this could potentially be a big area for occupational therapy. Okay, so this is something that you're actually going to be going over, and you already have seen this, right, Professor Bono? They've already seen the activity record in general, but they're going to be looking at one that's completed today.
Yes, they're going to be doing it today.
Okay, so I really like this, but I will tell you that it is difficult to get people to really complete it. And because it's so involved, it's got all these different things that they have to go ahead and rate, the 8 different questions. So we're lucky to have someone who did it. I typically have a person do it for a weekday and for a weekend day and see. And I really like it because what I'll do is I'll take an area like the pain or the fatigue, and I'll color code it. And so when I see high ratings, I'll go ahead and shade it in. I'll highlight it. And then I can begin to see it, and the person can begin to see if there are trends. So, is there something they were doing before they had this level of pain, or fatigue? So we can begin to problem solve and see like what's really going on here. This is just something that I've come up with just to look at pain. What activity, very similar, but without the 8 questions, and just, I want to know what the starting pain level is, what the pain level was during the activity, at the end, and any thoughts or feelings that the person has during that activity. And the reason why I want to know the thoughts and feelings is, as we'll talk about later, is the CBT. I want to see what's going on, what the person's thinking, and what their feelings are. Another one that actually was developed by occupational therapists is called OUCH, CPQ, Occupational Understanding of Challenges, Chronic Pain Questionnaire. Let me see if I can go there. Okay, so it's basically traditional kind of like pain location that you would see like in a PT clinic, and describing pain at the beginning, and then description of pain, and then they get into how it's affecting your daily life, and they have like open-ended questions like what can't you perform because of pain, what would you like the medical team to know, what would you like your family to know. I think that's a really great question, because as with any other kind of concern, that or condition, people have that we deal with as occupational therapists, we're not just treating the person, we're treating their significant others too. So, it can, it can affect the whole family, and it can affect their jobs. And I've even dealt with bosses in terms of dealing with how to get the person the most productive. So then they go in specifically, and these are all perception questions. How does a person perceive? So it's the person's own perception. So it's not a questionnaire like the Oswestry, which I'll show you in just a minute, which I'm sure you guys have seen before. So I kind of like this because it's open-ended, and it's not, a scale. Okay. I'm not going to go into this, but specifically there, for different areas, specific areas related to persistent pain, there's called the Tampa Scale of Kinesiophobia, which is to measure fear of movement related to chronic low back pain. That would be something that I think would be really relevant for us to look at. If someone's afraid to move, if they have perceptions of being hurt, they're not going to want to do certain types of occupations. So this is a good scale. And also the fear avoidance belief questionnaire. So it assesses the person's beliefs about the effects of physical activity and work on low back pain. There are I have found in the research, there are some reliability and validity issues related to upper extremity types of injuries, which is one of the major areas that we be working in. So I would caution you in using this for that. But again, if these are the kind of things we want to know. If someone is afraid of physical activity, that's going to affect their performance. So we really would like to know about it. And then there's a pain catastrophizing scale, and not meaning catastrophizing in a negative manner, meaning how the person perceives it. Yes, the word exaggerated is put here in the definition as a negative mental set, but it's multidimensional. It's got rumination to it. I can't stop thinking about how much it hurts. I worry that something serious will happen. There's nothing I can do. The person feels really, really helpless. And hopefully you could see, and we're going to be talking more about this later when we talk about CBT, how those kind of thoughts could go ahead and affect how the person performs, or whether the person actually does occupations that the person wants and needs to do. So this one has 13, This one has 13 statements that are rated from 0 to 4. And I've given you the link here. And I'm sorry, because of time, I'm not going to go through it. Amanda, is that okay for me not to open it?
Yes, but they just need to be aware of it.
Okay.
So
yeah,
they will be aware.
Okay. Okay, so going into interventions, a lot of research has been done about what really helps people with persistent pain. And one of the most powerful types of interventions that they have found helps people is neuroscience education, is actually teaching people about the neurobiology and neurophysiology of pain. It's not the traditional model of showing them injury or nociception to pain. It's really going ahead and getting people to understand why they're having pain and why is the pain persisting. And tomorrow, Dr. Underwood is going to show you a video called Tame the Beast. And this is an example of a really good video that is meant for clients to view, where Lorimer Moseley, who's one of the foremost pain scientists in the world, explains it in metaphors for people. There's also a lot of written materials, and hopefully you can see this. I have a book here by Lowe called Why Do I Hurt? A patient book about the neuroscience of pain, and then there's actually a workbook where people can work through certain concepts. Again, a lot of this material is metaphoric. I actually, to be honest with you, I don't love Lowe's book. His metaphors are about like business metaphors, like your brain's the CEO of the corporation. But some people might really, really like it. So it's important to kind of look around and see what's out there. There's a wonderful book by Lorimer Moseley called Painful Yarns. He's Australian, and the book talks about his journey into the bush. You know how Australians, they go into the outback and into the bush, and he tells these stories about how he's traveling with a friend who has this car that keeps on making noise. And every time it makes noise, the friend just kind of like beats the car, just pounds on it instead of paying attention to it. And eventually, of course, the car breaks down. So, of course, the metaphor is that there are signals that are coming to us all the time about a problem, and that pain is perceived as being something is wrong. It's a hazard notification to the person. There's something wrong going on. And if people continue to not pay attention to it, it's only going to get worse. So that's a really, really good one. And the video, Lorimer Moseley has multiple videos too. That he's very, very funny. He's a physical therapist, and as I said, a pain scientist, and very, very funny. Really enjoy. So in terms of interventions, our traditional role, and I've worked with people, I managed a work hardening program. I don't know if all of you know what a work hardening program is, but it's for people that have been injured on the job, and they come into a setting where, and we had OT and PT. Sometimes there's some trainers, athletic trainers. We do evaluations to see if the person can meet the essential functions of the job anymore. And then you actually condition them or do work hardening to get them ready to do their jobs again. So if an OT works with people with back pain, or other kinds of pain beyond the upper extremity. This is our traditional role, the interventions that we do, education about anatomy and biomechanics, pain reduction, work on occupations. See, here is work on occupations, body mechanics, increased active range of motion, strength, energy conservation. Here's work conditioning. Work conditioning is when people aren't ready for work hardening, where you're just conditioning them through exercise, trying to get the endurance up so they can do the work hardening. And then ergonomic assessments and some job coaching going into the actual job site. It's hard. A lot of places won't let you come in, unfortunately, to job coach. But I've been in several places where I've been able to do that, including for a mental health client that I was able to get in. Within a biopsychosocial model, the view of the current view of persistent pain. Again, our first intervention should be, as I said, neuroscience education. And studies have shown that this can lead to decreased fear and more positive perceptions of pain, improved attitudes about pain, their awareness, their cognition, physical performance, improved pain thresholds during physical tasks, outcomes, and it also can yield, very importantly, some neurophysiological changes, significant reduction in widespread brain activity. Remember when I said about central sensitization, that persistent pain can lead to this widespread brain activity, and so they've actually found that neuroscience education can lead to a reduction in that. And there's some evidence that there's some long-term effects of doing neuroscience education. One of the major roles in terms of occupational therapy, and it's not just because we work on occupations, but going ahead and increasing the performance of pleasant the occupations. Neurophysiologically, that can facilitate descending in inhibitory pathways and releasing of good chemicals and endorphins. When people enjoy doing what they're doing, they get those feel-good kind of chemicals going. And so not just doing the things that people have to do, but it's really important to get people to do things that they might like to do, that they would find that are really, really pleasant. And then this is not being done a lot, but sensory strategies. About that central sensitization that I talked about, what can happen is when people have central sensitization, they can become hypersensitive to touch, noise, bright light, medication, high and low temperatures. So we can use some sensory strategies, including what would be some of the sensory strategies? Let me see if I can come back. What would be some sensory strategies that we can help people calm their brains down?
Will you repeat the question, Dr. Underwood?
Okay, so the central nervous system is excitable, central sensitization. And so we want to use some sensory strategies to calm the person down. Okay, in our terms, in Dr. Allison's terms, maybe the engine is too high. People are hypersensitive to light, touch, lights, temperature. What could we do?
A weighted vest or a weighted blanket for deep pressure.
Great idea. Now, the only thing with the weighted vest and the weighted blanket is if the person has peripheral sensitization, we want to make sure we don't put it on where the person had, like you wouldn't put it on my leg because it would hurt. Great answer.
Deep breathing.
Deep breathing. What are the sensory strategies? Proprioceptive, like what?
So the deep breathing is that when you fill your chest, it's proprioceptive. It's like a stretch or a...
Oh, I see. What is Professor Bono really into? Sensory-wise. Aromatherapy. And there's certain scents that people may find very, very calming. Good answers. Good answers. Okay, for that peripheral issue of hyperalgesia, now he's going to talk about hyperalgesia and allodynia tomorrow. I'm not going to go into what those are right now. But there's some desensitization techniques like contrast baths. Some of you may have seen that in the hand clinics that you are. And now, see, you guys already came up with it, some deep pressure for sensitivity to light touch and some different textures to desensitize. Just like we desensitize when people can't stand certain kinds of touch. We could go ahead and work with the people to go ahead and desensitize by the different textures too. Okay, this is something that is cutting edge in terms of working on central sensitization especially. And this is called greater motor imagery. And there's a series of steps that you do with this. And PTs don't have time to do this. I'll be honest with you. My son says to me, why don't you come in and do this with my patients? You know, this is something that OT would do really well with. Of course, you'd have to be trained and do some research and understand this. So it's a series of cortical exercise. It's really aimed at reestablishing the cortical changes due to central sensitization and the pain experience. And so it's based upon the fact that we can hopefully restructure the brain. Tomorrow, Dr. Underwood is going to talk and show you the homunculus again and show you how when people have persistent pain, there's actually changes in the homunculus, in the areas the person has pain. In the homunculus, that part actually gets bigger. And there's also a concept called smudging, where the part of the body that is represented in the homunculus that has pain, the part next to it can actually start to hurt too. It's called smudging. So, so what we're trying to do through graded motor imagery is to increase or decrease body maps in the brain. And I don't expect you to totally understand this. I don't totally understand it yet, to be honest with you. I've done some research about it, but if I was going to do it, I have to do some more too. Just want you to be aware of this. So it addresses the primary somatosensory cortex, and it's been shown to decrease pain and sensitivity, improve movement in people that have central sensitization. Okay, so there are steps to this. There are 3 steps. And the first step is, and it sounds really weird, is that to work on laterality, left-right discrimination. They have found that people who have central sensitization and people that are in pain often lose the ability to identify left or right images of their painful body parts. So what you would actually do is show people pictures of the specific body part that they're having pain with and try you'll actually see that they're very slow in identifying it. And what you want to do is get them to get faster, and you're actually going ahead and training the brain. So there are actually norms, believe it or not. Accuracy of 80% and above is normal, and a speed of 1.6 seconds for neck and back, and 2 seconds for hands, feet, knees, and shoulders. Okay, so I'm going to show you a couple of pictures, and I'm going to ask you to come up with, as quickly as you can, left or right. You ready? You all ready? Tell me, Amanda, are you all ready? Yes?
They're ready. I'm sorry, I'm slow on the mute button.
Okay. Left or right?
Left.
How many people say left?
How many people say left? Raise your hand. Okay, they can't decide, so I'm pretty sure they failed this one.
Okay, come on, look at it. Look at it and move your hands around and see what you think.
They say it's the right hand.
It is the right.
But it's somebody else's right.
Yes, it's somebody else's right. And that's the point, is that you have to figure it out. Okay, here's the next one. It gets hard, or left.
Right.
Right, correct. Very good. That was faster. This one's really hard.
Left.
Yes, left. Wow, you guys are great. See?
We have a couple of like really good left-right experts.
Okay. I mean, when I showed these at the GOTA conference, I watched everyone kind of like, this one especially, putting their head down, around, trying to figure it out. Okay, so that's the first step. The second step is motor imagery. I'm getting echoing in myself, so hopefully I can continue talking and not listen to the echo. Okay, this is where you start out, and some of you may have heard of this. It activates motor cortical areas by actually having the person visualize, first starting out, just visualizing moving the affected body part. So wherever they have pain, yes, wherever they have pain, you have the person just visualize moving it. And then you progress to them actually moving it. And then if the person experiences pain when they move, you go back to laterality. You start again. And so as occupational therapists, this is an area that we could do well with having people visualize doing the occupation or part of the occupation. And I think that a lot of times we don't do enough of that. Now, Toglia, of course, with the DIA, she does that for cognition, where it has people plan ahead and imagine themselves going ahead and doing, the task and what it would look like and what it entail. Well, this is in terms of people having pain too. So I think that this could be very, very powerful. And the third part is something that you've probably, and you're going to hear about next week when discussion about prosthetics and amputations, is mirror therapy. I'm sure some of you may have seen mirror therapy in your field work. And that's where you have the person put the non-affected extremity. They put the affected extremity inside the box, and then the non-affected extremity in the mirror. And so you go ahead and move the non-affected, and it makes it seem like the affected extremity is actually moving without pain. So it goes ahead and gives input to the cortex that movement is actually happening normally. I think that's pretty neat. I think that's, it's done a lot with people for phantom limb pain, for amputation. But it's also done now for central sensitization for people with pain. Okay, one other area before we go in. I'm sorry.
Stroke too.
What?
Kaylin mentioned stroke too.
Yes.
Oh, it was Shelby. Shelby's on fire today.
That's great. One other area that, intervention I found in the literature that's just being started to be used is virtual reality. So it doesn't just produce a distraction from the pain, but it actually, again, stimulates the cortex. So people are actually performing through the virtual reality and can actually get pain relief because they're not really moving, but they're doing. And that's where occupational therapists could be so helpful, because that's what we do, is we have people do. And that's what these people need, is they need to do. And it's not just doing it, actually doing it, but we could have them plan it, imagine it, and the virtual reality, they could actually think that they're doing it. And the only thing I found in the literature as a caution was that some people may have problems with the head-mounted virtual reality, the apparatus, because if they have allodynia, which is pain in a certain area, it may be painful. So you just have to be, cautious about that and figure out what kind of apparatus to use. Okay. Is everyone, let me see. How are you all hanging in there?
They're doing great. They're eating it up.
Okay, so you're all awake.
They're vigorously taking notes.
Okay. Okay, so one of the areas that's being discussed a lot in terms of reduction of persistent pain is mindfulness meditation. And research has indicated that people that practice, and there's a lot of research out there now about using this, people performing this who have persistent pain, is that there's a reduction in present moment pain. Also, a reduction of negative body image. A lot of people with persistent pain have very negative body images. So they'll say things like, and it's really sad, my bad arm. You hear that with people with strokes too. My bad arm, my bad back. Also, mood disturbance. They're seeing a change in depression. There's anxiety and depression that can go along with it, not always, but can go along with having persistent pain. Also, reduction of drug use to manage pain. We definitely want that, because we want the opioids. We want people to be off opioids, and they can't get opioids today the way that people used to be able to get them. So they need another way of reducing pain. Also, stress, inattention, that's really important. Poor self-esteem, sleep disturbance, main area like we talked about. And it also has shown a reduction specifically to pain, to sleep, of the time it takes to fall asleep and to be able to get back to sleep after waking up. So mindfulness meditation can be really, really powerful. And like I said, there's multiple research studies out there now showing how effective it can be. So let me just ask, how much training have you all had in mindfulness meditation? Dr. Allison went over mindfulness meditation, right, briefly?
Not
Okay, does anyone know what the difference between mindfulness meditation is and regular meditation, other kinds of meditation?
They're shaking their heads no. I'm waiting for somebody to speak up. Anybody have an educated guess? Mindfulness is to change the way you're thinking.
Yes, it can change. Yes, it can be to change the way you're thinking.
Mindfulness might involve like purposeful meditation aimed at specific thoughts.
It could, yes. These are good answers. And I'm glad you guys are taking risks.
Which means it's not right. Anybody?
Okay. Thank you for those answers. Okay, so for some reason it's not letting me. Okay. Mindfulness meditation is about being present. It's about being able to pay attention to the moment. It's about being able to calm your mind and not have all these thoughts going on, which is very, very difficult. We all have, thoughts going on all the time. And we're used to now having a lot of stimulation going on. It's not like other kinds of meditation. It does, and it can, there's different kinds of meditation. One of them is sitting meditation, where you focus on the breath as the anchor. So it seems similar to relaxation sometimes, or to other kinds of meditation, but the point is not about really how you breathe, but to pay attention to the breath, to be present, to really be able to focus. So you can be mindful doing anything. So you can be mindful, like think about the morning, your morning care. Like how many of you, for example, maybe took a shower this morning and got out of the shower and you didn't really know whether you washed your hair or not. Couldn't really say what you did in the shower. Or how many of you drove here and don't remember the landmarks?
Anybody? They're all shaking their head yes.
Well, that's not being mindful. So you can do mindfulness with any occupation, and there's eating mindfulness meditation, where you pay attention to everything that you do as you eat. And there's walking meditation, where you pay attention to everything, every movement. I was trained by the people who started mindfulness meditation, University of Massachusetts Medical Center. And I went to a 7-day intensive retreat and we were doing mindfulness meditation from 6 o'clock in the morning till like 9 o'clock at night, and all kinds of mindfulness meditation. And we had a day of silence. And so we couldn't talk to anybody. And during meals, I had to force to pay attention to everything that I was eating. And I'm telling you, that was the best meal that I've ever had. Because I wasn't talking to someone else. I really was feeling the texture of the food, really experiencing the flavor, because I never really do that. The walking meditation was the weirdest. We were out in the field and looked like literally the Walking Dead. People were slowly walking and trying to really pay attention to what they were doing. So mindfulness can help people, and there are different kinds of mindfulness meditations that help people practice. It's a skill that you have to learn to do, and it takes a lot of practice. And there are apps that you can just download on your phone. One is De-Stressify that I tend to use with my clients. And there's different kinds of mindfulness meditation. I'm looking at the time. I'm going to come back based upon time. I want to make sure that we get to the CBT, and then we'll probably end. Hopefully we have time, we'll end. I have actually a mindfulness meditation for you all to do, to practice. One of the good parts about using mindfulness training with people with persistent pain is you also can do what's called grounding. So sometimes a person with persistent pain can start to feel really agitated and anxious and feel like this pain is never going to end. I'm always going to have this pain. It's just going to get worse and worse and worse. And what if when I go to this place, it's worse? So you can actually have the person ground to where the person is. Feel the chair you're sitting in. Put your feet on the ground and feel the ground. Look around. What do you see? And so you train them to ground themselves to where they are at this point, so that they stop trying to project into the future, not stay present. And so it's a really good technique for when people start to really get anxious and really start to think, oh, I can't stand this. I just cannot stand this. Okay, I'm going to go on. Dr. Allison said that she had covered CBT with you in general and wanted me to spend a little bit more time on CBT with you. So I'm going to go ahead and do that now. So cognitive behavioral therapy has been found through a lot of research to be very, very helpful for use with people with persistent pain. However, the Explain Pain, which is a book written about the biopsychosocial aspects of pain, it was a landmark book about it by Lorimer Moseley and his partner David Butler, two physical therapists and pain scientists. They look at it as managing pain, but not treating it. So there's a lot of controversy between like the psychologists and occupational therapists who use cognitive behavioral therapy and what they look at it. And actually, I went to a workshop with Butler and I asked him about CBT versus Explain Pain. And at that point, he really couldn't answer me. But then in 2000, the workshop was in like 2013, maybe. And in 2015, they came out with this article about the past 15 years of Explain Pain. And in it, they said that they finally addressed the difference between CBT and Explain Pain. And this is what they thought. Some early studies did indicate that they didn't indicate that it was more effective than other interventions for persistent pain. But the research has supported that there's reduction of catastrophizing. Again, not a negative term, just a term used in CBT that may last for a long time. And there's a lot of research on specific type of CBT for insomnia, CBTI, that is very successful for improving sleep of persons with chronic pain. Okay, so how do OTs, why is CBT, which usually you think about psychologists and counselors and social workers and people doing therapy, counseling and psychotherapy, doing CBT? Well, OTs have been using CBT for quite a long time, actually. And so I'm going to talk for just a couple of minutes on how does it fit in within the occupational therapy field. So we focus on barriers to performing the occupations that individuals need and want to do. I mean, that's basically what we do as occupational therapists. And this is really hard because I really would love to see you while I'm talking about this. And one of the areas that really affects the person performing the occupations are attitudes and beliefs about performance of their occupations. And certain attitudes and beliefs can be barriers to them performing their occupations. If you look at the OTPF, what we're really dealing with here are client factors, beliefs, and also mental functions like cognitive flexibility and the insight. If we look at MOHO, if we look at CBT and we try to interpret like CBT within this model, within MOHO, where CBT really is seen as part of our work is in the volition area. And as you know, volition are thoughts and feelings about competence, enjoyment, and value. And that people want to be competent doing the things that they do value. And within volition, it won't let me just scroll. Within volition, there are two areas: personal causation, which is a sense of personal capacity, where a person assesses, their abilities physically, intellectually, and socially, and self-efficacy, their sense of being able, or how well they have their personal capacities to achieve the outcomes that they want to achieve. So CBT within MOHO is used when people have feelings of less personal capacity or poor self-efficacy, which can lead to shame and fear of failure when performing their desired the occupations. So what can happen is if people have these feelings and attitudes and beliefs, they don't want to perform certain occupations, or they won't take risks, to perform them because they don't feel that they're going to do them well. My mother, for example, never learned to use the computer. And it was really frustrating to me. And I sat her down finally and said, "Mom, why won't you use the computer?" And her answer to me was, "I'm afraid that I won't do it well. So if I don't do things that I don't think I'm going to do well." So that attitude kept, no matter what I told her, and she was missing out on by not getting into the web, she just refused to go ahead and do it. They also won't believe that an occupation, they also may not believe that an occupation that they've done is performed well. And so cognitive behavioral therapy focuses on changing attitudes and beliefs about personal capacity and self-efficacy, and thus facilitates improvement in performance of occupations. I hope you all are following me here. So basically, we're working on client factors, and we're working on their feelings of capacity, effectiveness, and their thoughts, beliefs, and the attitudes about their performance, or even projected performance. So there are certain premises within CBT, and this is kind of behavioral therapy is the umbrella. And I know that Dr. Allison talked to you about Beck versus Ellis, CBT and RABT. I'm going to be focusing more today on CBT, and specifically a person who's interpreted Beck, David Burns. If any of you ever, and I'm teaching actually a specialty elective in the spring on CBT, and we're going to actually be using David Burns' Feeling Good, the handbook, which is a really it's a really great book for the public. It's not for therapists. It's for the public. But within cognitive behavioral therapy, there are certain premises or ways, paradigm that you have to kind of believe. And that the major one is that the way that people think, or the cognition related to beliefs about themselves, the events, the world, and other people, cause feeling and behaviors, not the events or situations. So you have to believe that other people cannot cause you to feel a certain way. An event happening doesn't cause you to feel a certain way. Now, of course, there are natural things like unfortunate deaths of significant others within our lives that, of course, are going to cause extreme sadness and grief. But in general, people create their own feelings and behaviors based upon the way they perceive the world, the event, another person, what someone said, and other kinds of activities. So within CBT, what we do is we help a person change the way he or she thinks, feels, and behaviors, and thus occupational performance. And so and we do this through active problem solving. So an example of this would be, I work in domestic violence. I work at a domestic violence center. And I have had many of the women that I work with, of course, have been told over and over again by the abuser, and unfortunately other people throughout their lives, that they're stupid and they cannot achieve anything. So here I am working with them on trying to go out and get a job, maintain a job, parent their children, manage money. A lot of them have never, ever been allowed to handle money, budget money. And so their thoughts about themselves, they really believe, I'm too stupid to do this. That's one of their beliefs. So I have to work with them on those beliefs in order to get them moving and doing things. I had one client I worked with, she wanted to go to school, become a nurse. It took over a year of convincing her, of working, where she finally felt confident enough to be able to go to school. So this can be very, very powerful and very integrated into what people, in terms of performance. That's why OTs, it's a barrier to performing occupations, just like active range of motion. Decreased active range of motion is a barrier to performing. It can actually be even more powerful than decreased active range of motion. So in terms of us performing CBT, what type of intervention is it? I would say it's a preparatory task. It also could be training, because we're training people, and self-advocacy. I actually have clients take around cards with them where we come up with a rational statement, and we're going to work a little bit on that in just a minute. And they keep the rational statement with them. So say that they feel like they're too stupid to do something. The rational statement for them, especially based upon their particular situation, might be, no one else can define my self-worth. I am competent. So also what approaches, it's creating, it's health promotion. We establish, restore, maintain, modify, and prevent. It's all the approaches, depending upon the person that you're working with and what the needs are. For me, a lot of times it's established. It's promoting health promotion, but it's established because a lot of the women I work with, as I said, have never been allowed to, for example, handle money, and don't know how to budget, and don't know how to do any of those skills. Some of them have done it in the past, and then unfortunately the abuser took over the money, so it could be restore. Okay, so CBT, and I know that Dr. Allison went through this, is and REBT is based upon what's called the ABC model. So A is the activating event, what's happened. B are the beliefs and the thoughts about it. That's where we're getting into really the meat of the issue here. And C equals the consequences, which are feelings and the behaviors. So for example, here is an example of someone who might have persistent pain. Might say, so A, the activating event for them is going to work when having pain. And B, some of the thoughts could be, I can't work because this pain will never end. I feel like if I go to work, the pain will definitely get worse. I tried to go to work last week and I was okay for about 2 hours and I started hurting, and this is not okay. I should only work when my pain is a rating of 2. And so for this person, the C, the consequences are fear, anxiety, and then avoidance of work. So you could see how this is directly related to occupational performance. This is keeping the person from doing occupation. Okay, so performing one of the first steps in doing CBT, and this is according to Burns, is identifying the erroneous or the irrational. Irrational is Ellis, is REBT, that's his terminology, or distorted cognitions or thoughts, and then challenging them or restructuring them. And Burns has 10 different, what he calls twisted thinking. See which ones you think you might have at different times. All of us have these. All or nothing thinking in absolutes and black and white categories. Overgeneralization, mental filter, you dwell on the negatives and ignore the positives. Discounting the positives, accomplishments or positive qualities don't matter. That's when someone compliments you and you say something like, oh, that doesn't really, that's okay. I did this, that doesn't really matter. Or the mental filter where, you say, but I didn't do well with this. Jumping to conclusions where people mind read. They assume people react negatively or thinking badly about them when there's no evidence of that. Or fortune telling where people predict things will turn out badly. Magnification and minimization where people blow things out of proportion or shrink their importance inappropriately. That's a little bit of what's the catastrophizing. Emotional reasoning. A lot of us do this. You reason from how you feel. I feel this way, therefore it is reality. Well, it's not necessarily reality because you feel a certain way. Should statements. People criticize self and others based upon these or similar words like must or ought to. Things should be this way. They have to be this way. They must be this way. Or labeling, where you equate yourself with characteristics or shortcomings. That's a lot. Again, the women that I work with, there's a lot of labeling. I'm not good at handling money, therefore I'm stupid. They label themselves stupid. Personalization or blame self or others for things you're not responsible for. You have no way of controlling. A lot of this happens, I've worked a lot with students too on, test anxiety. A lot of, think about all these ways of thinking that could affect how you feel about going into a test. If you especially think, you fortune tell and think, I'm not going to do well on the test. Well, you're probably not going to do well on the test. If you think I should get an A, as an absolute, or if I don't get a certain grade, then it's, if I don't get a grade in the 90s, then it's not good enough. It's all or nothing thinking. So nothing's good enough. So what I want you to do is go back to the slide and the statements I have on slide 34, and go ahead and write down the cognitive distortions from this list that you think are present, in each of the statements on slide number 34.
Dr. Underwood, is this where you want me to pause the recording?
Yes. Okay, I'll go back. So Burns talks about ways to untwist thinking or reduce irrational beliefs based upon the specific distortion. And the first step is to identify the distortion, which we already just did. And okay, so these are different strategies based upon what the distortion is. So one way is to examine the evidence. Is something, like, for example, is something always true? It's, what's the evidence that she's going to go to work and the pain's going to get worse? Another method it talks about is the double standard method, which you ask yourself if you would think about this in the same way if it was a friend of yours. So would you tell a friend of yours the same thing? An experimental technique where actually you would do an experiment to test the validity of the negative thoughts. So, go ahead and go into work and see if performing a certain task definitely leads to high pain rating. Maybe ask the person to go to work for 5 days and let's keep a log for 5 days and see what happens over the 5 days. Another one is thinking in shades of gray, where you actually have the person evaluate the performance or outcome in percentages that are not 0 or 100 if they have black and white thinking, or all or nothing. A survey method, would you ask other people if your thoughts or attitudes are realistic? We actually go around and ask people, what would you think about this? Defining terms, if you label yourself negatively, you ask yourself, what's the definition of this negative label? Like, what is stupid? What is, I'll say to women, okay, let's talk about stupid. What does stupid mean in terms of performing this occupation? What's stupid? And invariably, they'll get down to talking about how everyone else has told them that they're stupid. And I'll ask, but do you really think you're stupid? Or, what things have you done that, and examine the evidence, that are not stupid? Well, the first thing you've done is leave the abuser, which took a tremendous amount of courage to do that. You're taking care of your children. So how could you be stupid? And the semantic method for the shoulds, where you substitute language that is less emotionally loaded, like it would be better if, or more desirable, versus it should be this way. It would be better if I got 100 on this test. Somehow, and I've seen, actually people's shoulders, students' shoulders go down when we talk about this and change, I must get this grade on this exam, versus, it would be desirable. I've actually seen students just kind of sigh and relax. So there's many, many different ways of doing CBT. This is just one of the ways. There's many different, as Dr. Allison talked about, many different theorists within this theory. Like there's the people that follow Beck, the people that follow Ellis. I tend to be more of an Ellis person. And then now David Burns, who's very, very popular. So there's different methods, but in general, the point is to work on the barriers, the attitudes and beliefs that prevent people from doing the occupations that they need and want to do. Okay, so we just have a few minutes left. I'm going to ask Professor Bono and Dr. Allison if they'll do the mindfulness meditation with you that I have here while I'm not here with you.
We've got it. We'll do it.
Okay, and so I wanted to open for questions for the time that we have left, or any comments or questions.
Guys. Hang on 1 second. We've got a comment. I just have like a personal example. Like my sister, she's 19 years old and she's going through a bad breakup.
Oh.
This is like one of a few bad breakups. And she's kind of got this idea that she's not good enough.
Yeah.
And so it's taking a toll on her self-esteem. She's
Yeah.
not eating, like that kind of thing. I actually told her this weekend that she would benefit from CBT.
Yes, she would. Very, very smart. Very, very smart. Because it sounds like she's labeling, she's defining herself based upon the rejection. Very smart. Yeah, she would.
Everybody recognize their own thinking about performance, student performance, and some of the examples she was giving. Sometimes I overgeneralize in my relationship with my boyfriend. So, if he does one thing wrong, I'm like, oh, you do it wrong all the time.
Yeah.
I'm going to try to focus on that.
Yes, yes. This can be enlightening and important things when in relationships. And then, like, one of the, as I teach people too, one of the things in relationships and communication is to not say you always do this. And so that kind of thought, the overgeneralization will lead to the always, and a person, will get defensive then, what do you mean I always do this?
I'm combating that with my 5-year-old right now. I said, he's like, I always have to do the dishes. I was like, who did the dishes last time? Lydia. Doesn't sound like you always have to do the dishes. He was not happy with my CBT moment. Hang on, I got another comment. I was just looking at the different types of thinking, and I think that's where mindfulness comes in. Because like when you're so focused on the negatives, if you just pause, you can focus on the positives.
That's very, very true. And mindfulness, being mindful allows you to get more in touch with what you're thinking and feeling. It can lead to that. Any questions and thoughts about persistent pain and the evaluation and the interventions, or some of the concepts?
Have any questions about like the challenges with CBT or how to develop that questioning strategy?
Let me go ahead and add this too. One of the most important things, as with any treatment as an occupational therapist, that's very important if you do CBT with someone, is you have to have a really good rapport, and your humanism has to come through. Because when you question somebody, they can think that you think poorly of them. So you have to have a lot of trust that is established. When I work with the women, I don't start out doing CBT with them. I have to get to a certain point where I know that they know that I give them unconditional positive regard before I would ever do it.
There's a video of Dr. Underwood doing CBT, and she looks like she's being mean. because she's challenging them. But she has a relationship that will withstand that.
Actually, it's the one with Mary. Are you talking about the one with Mary?
Yes.
And so I was able to do that after working with Mary for about 5 years.
So if you've only been seeing your boyfriend for a few months, maybe not.
Yeah. Yeah. You don't want to do therapy with your significant others too. That's another thing. You really don't want to do therapy with your significant others.
No.
It can really backfire.
What avenues can they pursue for further training?
There are some workshops that you can go to. You could take my course.
This program doesn't get to do the advanced practice electives.
Oh, you don't get to do, that's right. You don't do specialty electives anymore. There are programs, there are workshops. Again, there's a lot of workshops out there for CBT. There's online training, but you want to make sure it's reputable people. You know, you want to research and make sure that it's a person who really has the background to train. And reading, getting the Feeling Good Handbook by Dr. David Burns. It's a really good resource. There are some REBT books out there by Dryden. Wendy Dryden is really good. Students who do field work with me, I train them in it.
For the students working in other populations, what other populations might find these types of interventions helpful as well?
Any population. I've done everything except I've done some pediatrics, but I haven't really done a lot of peds, and I haven't done hands. I've done it with all of my clients. I've done it with people with head injuries, and there's a lot of literature out there for working with people with head injuries. There's literature about working with people with schizophrenia doing CBT. They say, of course, if someone is psychotic, you're not going to be able to get very far. Dialectical behavior therapy that Dr. Allison likes has CBT as one of the modules. So with borderline personality disorder, I've done it with family members who are having a hard time. I've done it with people with strokes, you name it. People with developmental disabilities. There's been research using it, and mindfulness with people with developmental disabilities. With mindfulness, there's been some research with actually good results of family members of adults with DD, of helping them be calmer and sleep better.
I've seen mindfulness and aromatherapy used in pediatric for testing anxiety and ADHD.
Yeah. I've used it a lot with people with ADHD. I've used it a lot with students with learning disabilities and ADHD. Anxiety, a lot. It's
in acute care a lot.
Yes. And like I said, a lot with family members, because they're in crisis.
I use it at bedside to do guided visualizations and to be mindful and present in their body because they're so anxious with pain. That's what I'm saying is mindfulness, not CBT. Dr. Underwood, you're getting close to the end of your time. I want to thank you so much for all you've given us today.
Yeah, it was a pleasure to be with all of you. I wish I could have been with you more. Thank you for having me.
Thank you so much. And we're going to be going ahead and stopping the recording. and I appreciate all you have imported to us today.
It's my pleasure. Have a good end of the semester and break, everybody.